Hey everybody, it's Dr. Ben Pearl with FitFootU, and tonight I'm honored to have one of my professors, really one of my mentors, along with Scott Millay in the world of surgery anyway. I always look to Harvey Lamont in the world of pathology and Howard Palmarchek in the world of sports medicine. So there was a lot of good standouts at Temple at the time, and you were one of them. I mean, you did your residency at Doctors Hospital down in Georgia, a prestigious program, and then pretty much went right into teaching. How did that come about? I mean, it's almost like it was so seminal what you guys did.
Well, hi, Ben. Good evening, everyone. It's a pleasure to be here with you. I kind of had a fortunate situation. When I came out of podiatric medical school and completed those 4 years, I was fortunate enough to do the residency at Doctors Hospital, which was one of the preeminent programs, surgical and trauma programs at the time, with people, luminaries in our profession, such as Dalton McGlamory and John Rook and Stan Kalish and Louis Jimenez and Jim Bouchard and Tom Smith and Gerard Yu. And, I can go on and on and on the history of that program, but it was extensive training. I would say in my 3 years of residency, I did over 10,000 surgeries at that institution. And, subsequent to that, I was fortunate enough to be offered assistant professorship at the Pennsylvania College of Podiatric Medicine. Now as you know, the Temple University School of Podiatric Medicine. And I started in that institution and ultimately was there for 13 years.
Now, there's a lot that you rested on the shoulders of. I know one of your mentors was Gerard Yu. I'll tell you one thing just right off the bat that you may or may not know. I know you communicated a lot with some of your mentors when you either just socially or just when you had difficult cases. But even for someone like me that met him post graduation down at a Virginia Beach meeting, at our scientific meeting, he would share his email, and at 1:30 in the morning, I would get like a response back on ruling out an osteo, and he'd say something like, well, did you get a CRP, C-reactive protein? Which of course, was one of the golden things that Gerard Yu brought to us. He would always find one little kind of thing that would help you get through a case to help distinguish. What were some of the things that, other than his gravitas that he had in the profession, that that you feel were bestowed to you?
Well, certainly, for those who don't know, Gerard Yu was a podiatrist who also obviously did the Doctors Hospital residency program. He was actually my chief resident. When I was a first year, he was a third year. And unfortunately, he died at a young age of 50 when he had a heart attack, a sudden heart attack while walking on his treadmill. A great loss for our profession. As Ben has just outlined, he certainly will continue to be a leader in our profession, and his cousin Tom Chang is carrying on many of his academic excellence. He practices out in California, but I always said with Gerard, he expected 100% from you. When I was a first year resident, Gerard was very tough on us, and but in the same respect, he expected 100%, but he gave you 300%. And I think that's what you're alluding to, Ben, when you talk about how he would look at any case anybody had at any time. I remember, Scott Millay was my co-resident at Doctors Hospital back. We were co-first years. And Gerard Yu, like I said, and Jeff Boberg were our third years. And I remember one time we fell behind on some of our discharge summaries in the hospital. You have to have those completed in a timely fashion. And Gerard came up to us about 7 o'clock at night. And normally back then we admitted everybody. It's a funny story. I finished that residency in 1986. And outpatient surgery really became popular in 1985. And I remember when it first happened, we thought, oh my God, you're going to kill these people. You're going to send them home the same day you do surgery on them. And, we admitted everybody back then. So we had at times we had 50 or 60 people in the hospital from foot surgery. And so anyway, Gerard came up to us about 7 o'clock one evening when we were behind in these discharge summaries, and he said, "When do you guys think you might be done tonight?" We said, "Well, we got this and that to do. We got to still do rounds. We got a couple more H&Ps to do, probably 10 or 11." And he said, "Okay, so do you think you could meet me at my apartment at 11 o'clock?" And we said, "Sure." So we met him at around 11:15. He opened the door, and you could smell the Chinese food right away. He made us a big feast, and he and Jeff Boberg were there. We sat down. They said, "Come on in." And they gave us a beer, and we're eating Chinese food. We got done, and they said, "You guys feel pretty good now?" And we said, "Yes, sir." And he said, "Well, you're way behind in discharge summaries. So tonight you're going back to the hospital, and you're going to finish all the discharge summaries before dawn." And I remember we finished about 5:15 in the morning, and we had to be at the hospital anyway at 5:30. So in essence, we didn't sleep that night. But he was an intense person, but at the same token, he scrubbed everything. And I think it's something that anybody who's in a residency can really take to heart. If you're in our model today, a 3-year program, mine was a 3-year program back in the day. And if you're a 3rd-year resident, or even more, a 4th-year resident, or even a fellow, and you're working with lesser residents, like a 1st year or 2nd year, it certainly should be something where you can become a teacher. You should be in the operating room teaching those 1st and 2nd year residents along with the attending surgeon. I think that's something that Gerard really dwelled on, that in many programs we've gotten away from, where the 3rd year or the 4th year or the fellow just goes in for their case. And if it's a 1st year case, they're off doing something else. And I think there's a lot lost there. I think everybody should scrub every case they possibly can to maximize the education you're getting in a surgical residency.
Yes, that's a great philosophy. What would the Mike Downey today say to the resident Mike Downey? Is there anything over the years that you would say, just in terms of mental attitude and or anything didactically or specific about technique that you would impart to the resident Mike Downey?
Well, I think the key thing that's developed to me in my expertise over the years has been, trying to avoid becoming dogmatic. I think, when I did my residency at Doctors Hospital, we had some very strong personalities, and they wanted it done a certain way. And, I had the good fortune of, when I went to the Pennsylvania College of Podiatric Medicine, and I was a faculty member there, to work with other luminaries in the profession outside of my residency. Persons such as Harold Vogler and John Buchholz and Kieran Mann and, Gary Bauer and many others. So I really kind of synthesized all of their skills and what they did and what they believed in, and kind of became this, I don't know, maybe if you want to call me a mutt, my DNA, if you swiped my surgical DNA, it's a lot of different surgeons that gone into making up. And I think any resident needs to constantly have a thirst for knowledge. I say residencies are a lot of what you make of them. I find sometimes today residents think they're there just to learn surgery. You're really there to learn a lot more than surgery. You're there to integrate as a resident within the health system, within a multidisciplinary approach. And I think, the surgical skill comes down to not only your knowledge of foot and ankle surgery, but you have to be a much more well-rounded physician today. You got to be able to read MRIs. You got to be able to understand diabetes. You need to understand wound care. You need to understand, the effects of trauma on the soft tissues. There's a lot more to be learned than just the surgical skill. So surgical skill is one part of it, but I think staying there and being involved as long as possible. And I tell the residents today, and I'll leave this point with you, that you're only doing your residency for 3 or 4 years. You can't go back and do it again. So make the opportunity what you can make of it. Use those 3 or 4 years, make them the best you can, and work hard during those 3 or 4 years. I mean, it seems like you put a lot of time in going to medical school, but you got to put a lot of time into residency to maximize the outcome. Good input leads to good outcome.
you had some specific things you mentioned in our sort of pre-discussions about philosophy changed with triples and maybe doing, I don't want to misquote you, but double or single fusions. Can
Yeah,
you?
I mean, when I was a resident, the preeminent surgeons were, like I mentioned earlier, were, Dalton McGlamory and John Rook, and I know Dr. McGlamory had a philosophy of doing a lot of triple arthrodeses. He firmly believed at the time that the three joint complex, the subtalar joints and the midtarsal joints, worked as a unit, and that if you were going to fuse one, you fused all three. So we pretty much did triple arthrodeses on everybody. I would hasten to bet that both Scott Millay and I did well over 200 triple arthrodeses as residents in our 3 years. And we did very, very few, if any, subtalar fusions, isolated. And I can tell you, we really didn't during residency do any medial doubles. And I remember, when I first came to, Philadelphia, and I practiced at the Pennsylvania College of Podiatric Medicine, a lot of people believe that maybe you can do an isolated subtalar joint fusion, or maybe you can do an isolated talonavicular joint fusion. And certainly the literature has borne that out. And, many people do isolated fusions, as we all do today. The other thing is the medial double arthrodesis. I was always taught you have to do the subtalar joint through a lateral approach through the sinus tarsi, going above the perineal tendons, from laterally, and then putting the screws either from plantar dorsal across the talonavicular joint or dorsal plantar. And I really never did an attempt at taking down a subtalar joint and doing a medial double arthrodesis and doing the talonavicular joint and the subtalar joint. And I remember, I'll give her credit for this. Amber Shane, one time at a medical educational program, said, "Hey, have you ever done a medial double arthrodesis?" And at the time, I'd said, "Well, I've done double arthrodeses, but I'd never done it just through a medial approach." And she did one, and I saw it, and I said, "Hey, this doesn't look like it's that much more difficult." And I really, over the course of time, I think now today, for example, with tibialis posterior tendon dysfunction, if you're going to do an arthrodesis of the subtalar joint in the talonavicular joint, I think the medial approach makes a lot more sense. It's a lot easier to put the foot in a neutral position to minimize the amount of valgus that you're fusing the subtalar joint in. Whereas if you do the traditional lateral approach, it's a lot easier to take a cavus foot and put it into a valgus heel or correct the cavus through a lateral approach. So I really think biomechanically, when we're talking about surgical biomechanics, which I think is very important, if you ask me another thing, I think everybody should become good at it. It's not only sports biomechanics, but you got to transcend that and do surgical biomechanics. I mean, I think it's extremely important. I'm amazed today, and I know we're getting off on a tangent, but how many surgeons will evaluate a patient, never get them up to stand or get them up to walk. I see it all the time. They go in, they evaluate the patient in basically sitting in the exam chair, and it's phenomenally important to get the patient up, watch them stand, watch them walk, and some situations even watch them run, get them on a treadmill if possible, and examine them. So a lot of surgical biomechanics. I tell my residents all the time, and I'll leave this the end of this question with this is that if you don't make a good diagnosis, you can be the best surgeon in the world and you won't have a good outcome because you made the wrong diagnosis, fixed the wrong thing. So you have to be a good diagnostician as well as a good surgeon. And I really think some of my mentors, particularly John Rook, Gerard Yu, Kieran Mann, these were guys who were about as good as the profession has in diagnostics.
As far as some of your philosophical things that you mentioned, and you sometime when you have a chance, you should listen to a bit I did with Ben Onig, because even though it's biomechanic principles relating a lot to torques and joints, it certainly does with just regular locomotion. It certainly could apply to surgical principles. And one of the things that he mentioned, and I'd be interested in your take on this, was the idea that he had a knee replacement, and he ended up with a beautiful knee replacement, but then he had ended up having a hip problem, and I can't remember the specifics of the limb length that was addressed or not addressed, but maybe you could comment on some of the things where, you know, the old adage where you look at an x-ray, looks great, but then, you know, locomotion wise, what are some of the scenarios where you either have been involved with cases yourself or have seen others where the quote, you know, the x-ray looks perfect, but now you've ended up with bigger locomotion problems for the patient?
Well, first of all, that's a great question. First of all, we say every day we don't treat X-rays, we treat patients, right? And I think to start off that, one thing I'd tell anybody that's a physician of any type, but particularly a surgeon, is ask the patient what the goal is of their outcome. I'm always amazed how many times, and a patient comes in with a bunion, for example, and the surgeon looks at the X-rays, they eyeball the IM angle, the hallux abductus angle, the sesamoid position, all these factors, and then they determine the procedure they're going to do. When the real key is, what is the patient looking for? If you ask that patient, what are they looking for? They'll say, well, I want to get back into certain shoes. I want to be able to play with my grandkids. I want to be able to run and not have pain. And realistic expectations of the patient are key to whatever surgery we do, and it should help feed into the procedure you're choosing on that patient. The other thing that I think you're getting to and you're alluding to is the importance of the entire body and the entire lower extremity, certainly mechanically. And that's why I'm saying these patients, you need to get the patient out of the chair. They're not just a foot and ankle. If you're a foot and ankle surgeon, they're not just a foot and ankle. You got to look at the superstructure. You got to see if there's genuvarum or valgum, coxivarum or coxivalgum, internal or external rotation. I mean, all the other factors that go into the deformity that you're talking about treating. Because if you just treat the foot deformity and you don't pay attention to the limb length, you don't pay attention to other planar deformities of the lower extremity, you're going to have again, especially with major reconstructive surgery, a much poorer outcome. So now, that being said, there are times where the superstructural deformity is so severe that whatever you try and do in the foot and the ankle, or even the lower leg, may not fully correct the deformity. And that needs to be explained to the patient. And they to go all the way back to what I just said, they need to be given realistic expectations of what their outcome can be. I mean, you can't take somebody, for example, that's 65 years old and do a major rotational osteotomy on their tibia. That's just, that's too much for them to recover from. So they need to be given realistic expectations as part of that. But you certainly, I think, the patient needs to be looked at as a whole person, both what they're looking for and then what you can provide them.
You've made a career of kind of being the bailout guy from other doctors, whether it be a Charcot reconstruction, a bunion gone awry. I'm certain there are some lessons to be learned by you taking on this kind of liability. I mean, obviously you have the training to do so. And if not Mike, then who? If not Dr. Mike Downey, then who? I do know that one of your students, an upperclassman when I was at school, and I didn't remember this from one of your lectures, but I'm sure you said it, and I might have been at that moment just not totally with the course of the lecture, but you had a saying where when you do a revision surgery, where it go from the known to the unknown, and what you were describing was going either proximal or distal to the indurated tissue that no longer has those tissue planes. Maybe you can talk a little bit more about that, and then maybe take us to some more general concepts that you've had, other than kind of knowing what you're getting into with these type cases, but any other specific bits that you can impart.
Yeah, sure. I mean, it's, this has been my career. My career is kind of salvage surgery, saving the surgical failure, revisional surgery. I probably do more revisional surgery. I certainly over my career have done more revisional surgery than I've done first time surgery. I mean, it's kind of like the Life cereal commercial. They say, give it to Mikey, he'll eat anything. It's kind of like, send it to Mike Downey, he'll fix anything. And I think when a patient comes in, oftentimes they're angry, oftentimes they're upset. They want to vent against the prior surgeon, and many times at the first visit, it's almost like a psychology visit. You try and calm the patient down, you try and tell them where they're at, you try and give them realistic expectations again, and you try and give them hope. I mean, everybody wants hope, but it's got to be realistic hope. I can't tell them I can take something that's had, I have patients come in that have had 15 or 20 surgeries at St. Elsewhere. I can't make them brand new, but my goal, and a lot of times I'll tell the patient, and I actually hold my fingers up and I say, if you can see it here, I'll say, we're going to try and take an abnormal, arthritic, and painful foot, and we're going to make it abnormal, because I can't make you normal at this point. Less painful. Notice I didn't say pain-free. I actually say that to them, and perhaps remove the arthritis if they have an arthritic joint. So giving them realistic expectations is a key. I really try in most situations, I don't try and find fault with the previous treating provider or surgeon. I think, if somebody is listening to this presentation and this talk and is a up and coming surgeon, I would tell you, the more you just focus on the problem and try and steer the patient away from becoming litigious, it's generally a good thing. But at the same token, there are those patients that have been harmed. And if they've been legitimately harmed and truly malpractice has been committed upon them, then so be it. But I don't think anybody should accuse a previous treating doctor of any specialty of malpractice without having all the facts that are available. And a lot of times at that first visit, you don't have all the facts available. So if the patient is taking a litigious turn towards things when they're in the office and they don't want to refocus, then I'll tell them you need to get the prior records, whatever, if you want me to look at them. And I do think getting prior records is particularly important in these situations. Having what the prior operative report, what the prior surgeon has done, if they've had multiple surgeries, if they've had prior infection, what prior culture results have shown. All of these things can help you formulate the best plan for the patient. I think when most patients come in my experience, for revision, they want this to be the last surgery they ever have to have. If there's one theme, and that's not always possible. Sometimes, I had one recently where a patient needed an ankle implant, but their whole hind foot was in such malalignment, I had to correct the hind foot first, and then stage 2 will be the ankle implant. But in most cases, what you're trying to offer the patient is the kind of the definitive surgery that's going to hopefully have the best outcome for them, although maybe not going to get them back to normal or perfect. And that's what you, as with your experience, needs to educate the patient about. And somebody once said to me when I was chairman at the podiatric medical school, like we talked about earlier, I started there in 1986. But about 3 years later, I became chairman in the Department of Surgery and ultimately went through the ranks to full professor there. But somebody once asked me, at a seminar, they said, Mike, you should be trying all the newest things that are come on the market, all the newest devices out there, and tell us what we should be using and what we shouldn't be using. And I looked at the entire audience at that time and answering that question, I said, I disagree with that completely. I look at myself as kind of the last bastion of evidence-based medicine. I want to do the tried and true. I want to do the final procedure for this patient, try and give them the best outcome. Now, in some situations, that might be something new, but in the vast majority of situations, we all know what the tried and true is. So, when I'm looking at these patients, that's really where I'm coming from. Now, to get to the last point of your question, anytime we're working surgically through scar tissue, and I think especially true when we're doing revisional, like tarsal tunnel. That'd be the perfect example of what you described earlier. You have a patient that's had failed tarsal tunnel surgery. You have to go back. You're going to try and maybe decompress it a second time, maybe do an intubulation type of procedure on it, wrap it with something. usually it's better to approach that tissue from normal tissue. So I'll usually extend the incision proximally or distally above the area of severe scarring and work back into the scarring. And I today do almost all my surgeries with loop magnification. I just think it's, I discovered loupes way back when for nerve surgery with Lee Dellin, Baltimore. I took his course back, I don't know, 25, 30 years ago, before, nerve surgery became popular in our profession. And he introduced me to loupes, but I only used them for nerve surgery initially. But about maybe 12, 15 years ago, I started using them for all my surgery. And I honestly think, if you want to see the anatomy better, if you want to see the little bleeders, little vessels, little nerves, every little thing better, get yourself a pair of 3.5 times loupes, and you have to get used to them. It's kind of like getting used to looking through binoculars or looking through a microscope. It takes a little bit of getting used to, but once you get used to them, they become second nature. And if you look at almost all hand orthopedic surgeons or neurosurgeons, they all use loupes. And why aren't foot surgeons, we walk on the foot, why aren't we using loupes for the detail? I'm not saying you have to, but I just think in my hands, it's led to better outcomes over the years.
Well, we're always looking for something we can do tomorrow, and you've certainly offered us more than a couple, and equipment is certainly part of it. Give us a couple other things that you think are good in doing your own sort of self-analysis before we get to you, Mike. You had a lecture, I think, down at Virginia Beach. Unfortunately, I was at the beach. I didn't attend that particular one, but I think it was something about rescue procedures, taking you through a logical progression, doing your own sort of self-critique of what's going on with the patient, I think was the gist of where you were going with that lecture.
Yeah, and I think that's part of what I've already been saying to a large degree. It's doing what's most logical. Again, trying to do the most predicted procedure, and the other thing, I think, if it's your own complication, don't bury your head in the sand. I always like to say this in front of a large group, and it's amazing how many people laugh and shake their head if they understand. If you have a patient you've done surgery on, even if it's a hammer toe or a bunion, and they're having a complication, it, and you look at your schedule at the beginning of every day, and you look down the schedule, and you're seeing who's coming in, and you see that patient that's having the complication. I mean, your day doesn't become enjoyable until that patient's come and gone. I find the key way of kind of stopping that is being very upfront with my patients about complications. And I don't get defensive about it. Complications are part of any surgery we do. And I go in, I explain to the patient, they say, hey, it looks like my bunion's coming back. Hey, it's swollen. And I look at it on an x-ray, and maybe the osteotomy has shifted some. I tell the patient, your osteotomy has shifted some. The bone cut's not exactly where we left it. And I don't play a blame game. I don't say you must have kicked something or you must have fallen. I just say, it's not optimal alignment. And if I think it needs to go back to the operating room, I don't say to the patient, well, let's just see how it's going to do. I take the patient back to the operating room and I put it where I know it needs to be. And I probably don't go 6 months where I don't have a patient that either before they leave the hospital or the surgery center, we're taking a post-operative x-ray and I don't like something. And I took a fluoro earlier and everything looked fine. And now I take an x-ray and I don't like it. I say, don't let that patient go home. We got to take them back to the operating room, and we'll, wait till they wake up a little bit, consent them again, even if I have to keep them overnight, and do it the next morning. But, patients are very forgiving in that regard. They want the best outcome, and they know you're not perfect, and none of us is. And so, I think not hiding from your complications is a key thing. It seems inevitably complications come in and you discover them at the busiest part of your day or late on a Friday afternoon. It's amazing how they seem to time it that way. But you have to, fall a little behind in the office. If you're on time. You need to spend the time educating that patient. And let me tell you, once you educate them and you formulate a good plan for them, the next time that patient comes in, you won't have that angina waiting for that patient to be seen, because you've given them the plan and they've already accepted and they're, accommodating to it.
That's awesome. That's good. That's good stuff. I mean, I had a case today that came back as it was a revision, partial disarticulation of a toe, and it had staph epi. The path was hyperplastic on one, and I sent the other specimen to another pathologist that said osteo. So I was already suspicious, and on my second culture, it did come up a staph epi, which we usually don't chase down, but my clinical judgment was that it was infected. So I think going with your gut, I think, is important with any kind of case.
And remember, Ben, any of these organisms like staph epi, which is coagulase negative staphylococcus, these organisms today can be pathogens. I presented a case in Virginia Beach of a total implant where the implant was breaking down and draining regularly, and the patient was told, "Oh, you're just reacting to the implant." And they had taken multiple cultures, and every one of the cultures came back staph epi, no sensitivities done; coagulase negative staph, no sensitivities done. And when the patient came into me, I ultimately IND'd it. And when the staph epi came back and they said no sensitivities done, I said, please do sensitivities. If you take any culture, the lab will keep that culture for at least 7 days after they report it to you. And you can call the lab up and say, hey, I need sensitivities done. So if you have something unusual, it looks a little out of the ordinary, you think it's not just a skin contaminant, something where you're dealing with an osteomyelitis, ask them to do sensitivities. In the case I presented in Virginia Beach, it came back methicillin resistant Staphylococcus epidermidis. So it was a pathogen, and it's an implant, and that MRSE is a known pathogen in implant surgery. So you'd be amazed how many times, they say, oh, it's a normal contaminant, or it's sensitivities aren't done. But I'm not saying do it on everybody, because most of the time it is just a normal contaminant and is a benign organism. But if you're dealing with something unusual, certainly ask for those sensitivities.
Do you like more than 3 days to be off antibiotics to get a culture, or do you think even that is a little short to try to get an accurate culture?
Well, it all depends on the antibiotic they're on, but I think for most antibiotics, bioavailability we're using today, if you have them off it for 72 hours, you're pretty good. Mm-hmm. I would say that's typically what I take them off. So I have no problem with that.
Now we're in the last 2 minutes, and we can certainly carry over a couple minutes into another 5-minute session. But I do want to make sure that either way, you've got something coming up later in September. It's going to be a gathering. I guess you call it the Great Debate. Tell us a little bit about that, and we'll continue on if we get cut off here.
Well, thanks, Ben. It's very exciting. We have a Podiatry Institute seminar in Philadelphia, September 16, 17, and 18. So it's Friday, Saturday, Sunday. And one of the things we're doing this year for the first time is what we're calling the Great Debate. And we have 4 graduates from the Podiatry Institute. Scott Millay and I told you Scott was my co-resident. And then there was another year where there were 3 great residents that completed the program. Tom Chang, who practices in Santa Rosa, California, Luke Ciccanelli, who is in Vigo, Spain, and Dave Caldarella as well. But Tom Chang and Luke Ciccanelli are going to come to Philadelphia and debate Scott Millay and I. And we're going to do 2-on-2 debates for that seminar. And we're going to look at everything current today, from plantar fasciitis and PRP injections to Charcot foot reconstruction to the lapidus bunionectomy and hypermobility and all the instrumented techniques used for these bunion procedures today.
It sounds awesome. Let's
surgery.
Let's take a 2-minute break. We'll get this under wraps, and then we'll come back for a 7-minute bonus round on just that seminar and a couple finishing points.
Great, thank you.
All right.